Okay, good afternoon, everyone. This is Bethany Hamilton from the National Association of Community Health Centers State Affairs team. I want to welcome you to today's webinar. Today's date is July 10th, 2018. The time now is about 2 p.m. Eastern Time. This webinar will be recorded. Just a couple of logistics to get out of the way, and then we'll get right into our substantive presentation. For those who have joined us from around the country, we will not be able to unmute you to receive questions orally, but we will ask that if you are having any trouble getting the audio, you should have logged in first via the WebEx, and then you'll use the instructions that are currently appearing on the screen to either dial in by computer or dial in by phone. We would recommend that you dial in by phone because that's the best audio connection that we found to date. To do so, you click on the Quick Start tab, then click on I will call in, and then follow the instructions in the pop-up window that will allow you to either dial in by phone or use your computer's audio. Everyone will be entered on mute upon entry, and you will not be unmuted. So we would strongly encourage you to utilize the chat feature that's available in WebEx to send us your questions. If you do see on your WebEx screen that there's a Q&A option to submit questions, that's perfectly fine as well. We'll be moderating the chat box as well as the Q&A box on our end. We encourage you to send those questions in right up until the end of the webinar. Even if we run out of time, we'll keep a log of those questions and attempt to at least get some trending questions answered in a follow-up to today's webinar. So you would click on the chat box. It should be blue as it's active, and then you can chat to all attendees. You might even be able to select on your end as an attendee the ability to chat directly to a specific presenter or panelist. All right, if you're having any issues hearing us, because we did test out our sound ahead of time, please just go ahead and double check the level of the volume on your current device. Just remember, we emailed out some information to log into today's webinar, but if you are having any trouble at all, as technology is a little bit unpredictable sometimes, go ahead and just shoot us a quick email at state@nachc.org. So that's state, S-T-A-T-E, @nachc.org. Following this webinar, for those from the PCA that are joining us today, and we're, by the way, joined by a pretty broad and open audience, health centers or any other health center advocates or interest folks alike, we'll be making the webinar materials available. For the PCA folks, that will be available in the Dropbox account that you've received access to. And if you are from a PCA and don't have access, shoot us an email again at state@nac.org. Okay, with that, let's go ahead and get started. Today's webinar is going to discuss the environmental scan of health center integration of behavioral health and SUD or OUD services. That's substance use disorder or opioid use disorder services. We're joined today by Dr. Kima Taylor of Onco Consulting, Jennifer Taylor, Acting Director of Federal Affairs here at NAC, Dr. Ted Wilmslow of the Ohio Association of Community Health Centers, and Rachel Marino of Valley Health Systems in West Virginia. We're hoping that what you will gain from today's webinar is first a better understanding of our state landscape analysis scan here at NAC, which really helps to inform and enhance our policy agenda around behavioral health integration as well as substance use disorder treatment, including opioid use disorders. You'll also hear and learn from a PCA who's really delved into its specific role and perspectives at the state level based on their state environment. And then you'll also hear some key lessons learned from a health center engaged in integrated behavioral and primary health care, and that is with an SUD treatment program. So first, we'll be hearing from Jen Taylor. Again, Jen Taylor has been here with NAC for several years now. She's currently our Acting Director of Federal Affairs with the Public Policy and Research Division. Jen's going to be going over some primarily federal policy updates. You all know Jen very well over the years, so I'm going to just quickly segue and give you some quick updates, or excuse me, intros on who our other panelists are. Dr. Kima Taylor is a board-certified pediatrician. She practiced medicine at Unity Healthcare in D.C. She served as director of the National Drug Addiction Treatment and Harm Reduction Program at the Open Society Foundation. She's a deputy commissioner of the Baltimore City Health Department and has also served as a legislative assistant to U.S. Senator Paul Sarbanes of Maryland. Her professional achievements go on and on, but just quickly noted, her education also includes, she attended Brown University School of Medicine, Georgetown University for her residency program in pediatrics, and she also has an MPH from the Harvard School of Public Health, where she focused her research on exploring state legislative remedies for racial and ethnic health disparities. We are also joined by Ted Wilmslow of the Ohio State, who received his medical degree from the Ohio State University College of Medicine. Ted, I'm sorry, I'm a University of Miami Hurricane, so perhaps that was a little bit of a trip up because of something subliminal going on there with our football rivalries. So back on topic, Dr. Wilmslow is with the Ohio Association of Community Health Centers. He's their chief medical officer. As mentioned, he went to Ohio State University's College of Medicine and completed his family residency training at Mount Carmel Medical Center in Columbus, Ohio. He has over 30 years of experience as a clinician and has held several leadership roles in family practice, residency training, medical student teaching, local and state professional associations, free clinic and homeless shelter, healthcare delivery, public health, and PCMH advocacy across the state of Ohio and really across the country. Today, in his position as CMO of the Ohio Association of Community Health Centers, with over 51 F2HC members serving 750,000 patients across the state, he really does help to spearhead their 176 of them who have become PCMH recognized. He serves on the Better Health Partnership Board of Trustees in the Ohio University Heritage College of Osteopathic Medicine Advisory Board. I could go on and on with Dr. Wilmslow's achievements as well, but we are also joined by another colleague from the field, and so I want to make sure she's properly introduced as well. Her name is Rachel Marino. She's the Administrator of Behavioral Health Operations at Valley Health Systems in Huntington, West Virginia. That's an F2HC that serves both West Virginia and southeastern Ohio. Rachel holds a Bachelor of Science from Oregon State University in Public Health, Health Promotion, and Health Behavior, as well as a Master of Science in Healthcare Administration from Marshall University. At Valley Health Systems, Inc., Rachel oversees daily operations and development of the Department of Behavioral Medicine and its programs, including Integrated Primary Care and MAT, or as everyone should know, medication-assisted treatment. Over the last 2 years, Rachel has worked with the Human Resources Department to recruit at least 12 additional licensed behavioral health providers, contributing to the expansion of the Behavioral Health Services Program at 2 additional health centers within Valley Health Systems, Inc. Entity. She represents Valley Health on community and statewide coalitions aimed at addressing substance use crisis across the state of West Virginia and its surrounding region. She has a special interest in addressing the social determinants of health and working with community partners to address the needs of health center patients. Prior to joining Valley Health, she worked as an assistant clinical manager at Huntington Internal Medicine Group, and she has a breadth of experience prior to in the nonprofit sector, both in social services and behavioral health care, where she cultivated this passion for helping others who are underserved. So with that, I'm going to pass back to Jen Taylor, a colleague here at NAC, for presentations at the policy federal level updates. Jen?
I'm going to try to keep this pretty short because, as you hear, you have an impressive lineup of speakers today, and I don't want to take up really any of their time. Just wanted to quickly kind of help set the table a little bit about where we are from a policy perspective. Obviously, lots and lots of activity happening at state levels in terms of improving integrated behavioral health, looking at substance use disorder, and certainly looking at the opioid crisis. I think you're going to hear a lot more about what's happening at that state level in just a moment, so we wanted to take a couple of minutes to also just clarify that Congress is obviously very interested in these issues as well. I will say the bulk of their work is very specifically targeted at opioid use disorder and at the opioid overdose crisis, so they haven't been doing as much more broadly in substance use disorder and in behavioral health integration, and that's something we want to keep working with them on. But what we have seen is a series of hearings and markups in both the House and the Senate The House of Representatives has passed almost 60 bills related to the opioid epidemic, largely, honestly, in a bipartisan way, which is rare these days. They're taking a pretty broad approach, looking at this from a variety of perspectives, but I will say, you know, while we are optimistic that some of the bills they have passed will ultimately be helpful in kind of nudging us in a better direction, one of the challenges that remains here in Washington is just really an unwillingness and an inability to get together to figure out how to spend money and really invest it in some of these problems. And unfortunately, there aren't a lot of low-hanging fruit of, you know, completely bipartisan ideas that cost no money and don't take some work. So we are grateful that they're starting in the right direction, but we want to keep working with them to keep pushing them further. And I think that the work we're going to hear about today is really helpful in doing that. We've been able to utilize the results of Dr. Taylor's scan to really inform the process at Congress and to lay down some tracks for what we hope to be the next couple of years of work in this area. We are still waiting on the Senate to take their final action on the bills that have been passed to date. So I won't spend time today prognosticating exactly what the final package will look like. We do expect the Senate will move sometime potentially late in August and possibly even after the election. I will tell you, I think there is universal interest, Republicans, Democrats, House, Senate, in looking at these issues, but they are working with very different dynamics that influence their process. So some of this is a result of politics. You'll see that every member of the House of Representatives is running for election this year, and so certainly they were incentivized to come back home and show the work that they've done. So their leadership there wants every member to be able to come home and say, look, we passed 60 bills, we're working on this issue. The Senate has kind of a different dynamic. So when it comes to politics, you know, only a third of the Senate is up for election, and quite frankly, the third that's up for election are much harder seats to defend for Democrats. And so the Republican leadership in the Senate doesn't have the same incentives to give those members wins before the election. So while I do think there's genuine interest in getting something done, we may see that on a much slower track. And again, that's maybe why we won't see final action in this area on this round of bills until after the election. The other piece that's influencing it is just simply procedure. The House is generally moves much faster. It's easier to get floor time. It's easier to pass bills. And so when they have ideas, they can kind of generate hearings, get them on the floor, get them passed in the same week. And it's much, much harder to get time on the Senate floor, which is going to be compounded by the fact that they now have a Supreme Court nomination to consider and a variety of big and partisan issues on their plate. So we do anticipate, like I said, additional action, but we're not exactly sure when. I will say of all the health care bills that they could possibly consider, essentially we think this opioid package will be the only one that actually makes its way through. So it is very much prioritized, just on a slower track. Again, I think without belaboring any of the bills in detail today, I'd be happy to talk to you offline about any number of them. I just really wanted to give thanks to the people on this call and to Dr. Taylor for all the work on this environmental scan, because we were really able to give great feedback to Congress based on the results of that work. We were able to help try to get incentives for health centers to be able to start and expand MAT programs. We're able to talk about the challenges associated with, 42 CFR Part 2 privacy issues, able to really talk to them about the workforce needs that are essential and try to help get things like loan repayment programs and real longer-term investment in building a behavioral health workforce. So I'm very grateful to all of you for engaging in this process. For those of you who have not yet had a chance to talk to Dr. Taylor, we hope that you will stay with us again as we move forward, because no matter what ultimately passes, we've got more work to do here. So I look forward to continuing to work with you guys to get Congress to think more broadly about substance use disorder, not just opioids, but as part of the bigger picture, to really get them to think about long-term investments like reimbursement and clinical workforce that really support an entire integrated behavioral health approach, again, not just looking at opioids, while they're very important. And I think that you guys are just going to be instrumental in that work moving ahead. So thanks for taking the time with us today. I won't take any more time away from our great speakers, so I will kick you over to Dr. Kima Taylor, who can give you more information about what she did this year.
Great, thank you, Jennifer. So I really, like Jennifer, want to give a special thank you to all of the people who spoke with me and taking the time to help me understand all of your amazing work, where the barriers were, and where some of the catalysts were. I'm going to skip any big preamble about the findings. Obviously, you guys know and live these findings every single day, but your participation really helps to demonstrate that there's shared catalysts and shared barriers that can and should be addressed across different states, geographies, demographics, while we still do need to do more targeted policy work to address regional differences and racial and ethnic differences. And so I think the exciting part is that there really are some common themes that we can work together on. Oh, good, this slide. Process. Just to give you a really quick background on the process, I was really excited when the policy team asked me to come on board and do this environmental scan, and they really wanted to get a sense of what policies could or should be added, changed, removed on both the federal and state level as folks are doing work in this opioid use disorder time period when we all really know that it needs to be how do we create a comprehensive substance use disorder system. And it was great because while doing this analysis, the FQHCs really, many of them are at the forefront of helping people understand how to better holistically care for patients. So they tasked me with looking at 15 different states that were different in terms of geography, state regulations, Medicaid expansion, not, carve-in, carve-out, different populations, which of course is just a slice of the United States, but what it offers is, again, the ability to show what are the barriers and catalysts that exist across the country. I talked to both PCAs and also health centers that were firmly doing some of this work. And the PCAs really gave a great whole picture, not only, about the ones that are doing integrated care or at the early stages of integrated care, but also about what are some of the barriers to even trying to start doing integrated care in the first place, and frankly, why others started but had to scale back or leave because of sustainability or other issues. And then, as I mentioned, talked to health centers, many of whom were early adopters, and many of whom were early adopters before this opioid use epidemic because they really saw this as a patient need and kind of scrabbled together care and funding and others to do integrated care so that once the opioid use disorder came to the fore, they were better equipped to be able to address it. So next slide, please, Bethany. So first I want to start with some of the facilitators, and I think these are important. One, because the barriers are so many, we know all of them, and I wanted to kind of start on a positive note. But across the board, for many of the early adopters, they felt that Medicaid expansion was a boon, and for those who did not have Medicaid expansion, they felt that that was obviously a problem. And so the understanding that the importance of the ACA and its need to remain in place and have this expansion period that doesn't hopefully have additional work requirements or other things that make it harder for this population allowed many of the early adopters to innovate. They didn't have to, they knew there'd be a way to sustain this work if they could get the upfront funding to put it in place. And that really made them feel that they could embark in this arena. Another facilitator was really a strong PCA, and PCAs as partners, supporters, vocal advocates, and translators. So often when the PCAs would say, well, what is the policy change that could help you do this better? The FQHCs could look at some of the policies coming out and saying, no, that's not reality. What you need to do is tweak X, Y, Z. And the PCAs would have the relationships with the administrators and legislators and others to help make that a reality, and a reality that really focused on the FQHCs. A lot of policies come out focus on kind of substance use disorder services or healthcare systems writ large without an understanding that FQHCs often have a different payment system. And so the PCAs really help to translate that reality. Another facilitator was having an informed legislative champion. Now, some states had to work to create this legislative champion, but having someone who really understood that substance use is a chronic disease, that substance use requires a team to help people improve, individuals, families, and communities improve and have the supports they need. But also the legislative champion that was able to see that we need to create a system for substance use disorder, not just opioid use disorder, helped many of these centers. And lastly, having enthusiastic foundation partners. Time and time again, when the feds or the states weren't supporting some of the upfront costs, many of these early adopters were able to look to funders and foundations that had bought into the idea of integrated care and really supported them financially, emotionally, with administrators and others. And, some localities were lucky enough to have many foundations and others aren't, but that was definitely noted as an important catalyst. Next slide, Bethany. So now we get to the barriers, and unfortunately there's many barriers, but the really exciting thing about talking to the PCAs and the FQHCs is that many of you have thoughts on how to overcome these barriers, how to mitigate them, how to work with other partners to still give the patients the care that's needed. The first is stigma, and there is not a person around who didn't mention stigma, and the hard part with stigma is that was in any variety of ways. It was the stigma of the healthcare system that hadn't had to serve people because they thought it was a moral failure and didn't have the capacity to say what quality care was or have the capacity to reimburse appropriately for services that were needed. It was stigma of staff and providers who didn't want to see, those patients, quote unquote. It was the stigma in terms of the patients feeling those negative feelings and not wanting to disclose that they have a substance use disorder and how that affected outcomes. And interesting, not just outcomes of the individual and families, but the outcomes of their physical health. And then the healthcare centers weren't getting the positive outcomes they needed, and that cycle of not having that not having those holistic services. And then there was stigma between the opioid use epidemic and substance use disorders writ large. The fact that many people recognize that now all of a sudden we're talking about substance use as a chronic disease, when before there was a criminal justice response, and the class and race and other implications that are still unfortunately baked in as we talk about a lot of this opioid use epidemic. So stigma was one of the biggest barriers, and many of the FQHCs really had creative ways of doing training and education, getting their boards and others on board so that they could get their boards to understand the importance of providing this care and kind of helping staff and others through the stigma and continuing to do so to offer holistic care. Another big barrier was lack of infrastructure, and this ranged from not having the space to have the privacy to do behavioral health services, so needing capital investments, which very few funders or grants are willing to provide, but also the need for training, and not training just of clinicians, but training of the whole staff, being able to go and understand how to provide integrated care, why it's important, what processes are needed, how to change the charts, et cetera, in order to provide and get the data needed to provide the best care possible. And then lastly, I would say startup funding. Sometimes that meant changing the electronic medical record, but sometimes that meant concrete hiring of staff that even though they're sustainable in the back end, you need that upfront money to be able to hire them. The lack of infrastructure was a smaller hurdle often for FQHCs that started as community mental health centers and became FQHCs, and it was noted that there really needs to be discussion on FQHCs, those differences, and how you can build infrastructure recognizing those differences. Second, and again, you guys know these issues, but lack of workforce, both getting and retaining. And it came up as much as there's a huge difficulty and no pipeline for the behavioral health workforce, there's also the recognition for a need of primary care workforce, and especially in some of the rural and other areas, and a primary care workforce that understands and is excited about providing integrated care. So that did come up, but really what came up was the lack of behavioral health workforce and the fact that once often people are hired, it's really hard to retain them because they're getting better pay in other places, better hours, et cetera. MAT bias, medication-assisted treatment bias. This came up in many ways. The first being just a bias against medication-assisted treatment writ large, that it should not be given, it's not quote-unquote true recovery, that it's not something that should be part of the substance use disorder or opioid use disorder lexicon. But then once people accepted that maybe medication-assisted treatment is an evidence-based thing to do, there would then be biases against the different types. There's no real methadone relationships, and obviously FQHCs cannot provide methadone unless they're an OTP. But there were not a lot of relationships with methadone centers, often because, going back to stigma, many states don't reimburse for it, there's the NIMBY issue, and so there aren't a lot of methadone clinics. So a lot of the conversation was really between buprenorphine and naltrexone. Who can get it, who can't get it? And unfortunately, a lot of the discussion was not necessarily on what the patient needs or wants, it was more on what the state or clinicians decide is the best to give. And sometimes that was based on moral reasons as opposed to clinical reasons. And the discussions around that, whether it be One is a drug that just allows you to continue your opioid use. Another that it's, you shouldn't cut people off cold turkey. The cost, there's a lot of packed in there, and so a real need for those who are successful and thinking about how to provide what the patients needed in a myriad, real hard conversations about what they could offer, how they could offer it, and how they could link people up to those services. But the MAT bias was something that came up over and over again as people work with not even just internally, but other treatment and substance use disorder systems, much less policymakers. Privacy, 42 CFR, which was alluded to and is important and that clinics are working through, but also I want to say there was discussion around privacy for the population. The fact that it's a justice response, the need to protect the privacy of the clients because of immigration and ICE enforcement and because of justice system enforcement, and how to make sure that patients are assured the privacy so they can disclose that they have a substance use disorder and can get the treatment they need. Sustainability, I'm actually going to leave sustainability for last because that was the biggie. Rural barriers, I kind of brought up before, the providers, lack of providers, transportation, and the Medicaid kind of arcane rules around telehealth, who can be a receiver, who can provide it. But the interesting thing I think that came up about telehealth is people really want to see telehealth amongst a range of providers, not just clinicians, social workers, peer recovery, and have reimbursement for that. So people were thinking really creatively. Unfortunately, at the current time, a lot of that creativity they're paying for themselves and eating their cost, but there were some creative responses. The last few, lack of Medicaid expansion was something that came up over and over again in the places that didn't have Medicaid expansion, and really came up with the need of those states to really talk amongst each other to think of how to creatively move not only the Medicaid expansion needle, but if you don't have Medicaid expansion, what are some of the responses on a policy level that you can have to create broader substance use disorder services? Because often these states are coupled with the fact they have a low tax base and there hasn't been a lot of investment in community mental health or substance use disorders or services as it is. And so the real desire and need to talk amongst each other about how you work within those systems, how you get foundations to think differently about supporting this work. There were few services for special populations. Many people are just trying to provide the basic holistic integrated care, but some sites were doing work around with pregnant women, with justice populations, kids, and adolescents, but this is something that not only policymakers haven't really spent a lot of time on, but that infrastructure hasn't been really built within the behavioral health space in a positive way up till now, and it's a place that I think federally qualified health centers are often at the forefront. Last is really the competition, the false competition with community mental health centers and the FQHCs, and the competition that is created by policies and policymakers of who can serve what population, why they can serve them, where it can serve them. So for a lot of FQHCs who want to do the integrated work, they are stymied because they cannot do it by statute, by regulation, by laws. And this is something that many people wanted to see eradicated, but of course it's a very sticky wicket because you're talking about this perception of taking money away from one group and giving it to another. So lastly, I want to end on the sustainability issue, and there are a couple different issues that came up with this. One, I really wanted to talk about the federal level and administrators. There was a great conversation pretty much ubiquitously about how federal agencies give out grants and the need to talk and work with state officials. So if you're going to give out an SBIRT grant, make sure you talk to state officials to say that this needs to be sustainable, these are the codes that need to be built, because it's really frustrating to start a program and not be able to sustain it, and it makes people leery of engaging in grant pursuits in the future. Another issue with sustainability is, as we talked about, Medicaid expansion. But for all states, particularly the states that don't expand Medicaid, there's no funding for uninsured. So even as everyone's talking about what we're going to do for Medicaid, there's not funding and infrastructure for the uninsured. And so often, if you're providing this care service within an FQHC, you are taking care of everyone, and that makes it sustainable because you can't actually afford to take care of people without insurance at the same level that you'd like to, and it's eating a lot of cost at a time when funding for the basic services are often in jeopardy. And so it's really hard for people to say, I'm going to engage in creating an integrated system when you can't even guarantee that you will have staffing for the baseline primary health care services. So as I said, you guys know a lot of these barriers, but the exciting piece is that many of you were able to see where those policy interventions could occur, and that's some of what also came out with the environmental scan, and that's the piece that the policy team has really been looking at and is excited about. And I have to say, like, my biggest excitement with the policy team is the fact that, as many of you mentioned, they are focused on substance use disorder services. They are not talking about only opioid use disorder services. And that is something that was heard loud and clear, appreciated before, but really appreciated to hear the FQHC voices and PCA voices really trying to hammer that home. So without further ado, like I said, I really like to end on positive notes, and so I'm excited to say that Ted and Rachel are going to show examples, one from the PCA perspective about how to think about doing some of this work, and then from, the center perspective. So without further ado, Ted.
Very good. Thanks, Kima. And I'll go to my first slide if I can, and we'll get started into a brief overview of what we've done to address one of the barriers that Kima identified, and that was lack of workforce. Workforce from our membership was over and over and over stated to us to be the major concern they have, and the major concern especially about how they're going to better integrate behavioral health in primary care and how they want to try to address substance use disorder using their available resources, including the people they can find to employ and maintain an employment. So we've put a very strong effort together that has 4 components to it to try to get at this issue of maintaining a workforce that is well prepared to deal with comprehensive interprofessional intervention for patients' needs. And the 4 parts are, number 1 is the health pathways, and these are identifying and nurturing students who are many times our patients who have a capability to pursue a health career, have an interest in that, and hopefully for our own practices, we can mentor them and be role models to them and assist them during their journey through training in the health profession, ultimately returning them back to our own health centers to join our workforce. So we've identified a number of upstream programs that our health centers can participate in for identifying and nurturing relationships with students all the way through, from high school all the way through their pre-professional career stages. Secondly, and the major emphasis today will be the Ohio Primary Care Workforce Initiative, which we created to get at teaching more professional level students during their training so that they could see what an FQHC looks like, understand what interprofessional team care is about, and by doing that, get to know them better, have them know us also, and hopefully over time be able to recruit them into our practices to join us when we see good fits occur. At the next level, number 3, that's when especially physicians get to the point of primary care specialty training, and that would be family medicine, internal medicine, pediatrics especially. We have a very narrow channel that all of our students who are interested in careers have to go in Ohio, in that we have fewer primary care training slots at the graduate medical education level than we need in order to keep them in Ohio, get them trained, and hopefully have them practice in Ohio in primary care. So we've devised, and that started earlier this year, a primary care physician workforce collaborative, because as we've seen it, the nurse practitioners and PAs have done an excellent job of expanding their capacity to train and place their graduates around the state. They're doing a very good job, and the House of Medicine has been largely stuck for at least 10 years, at least in our state, with no expansion in our ability to train at the resident level primary care physicians that we'd ultimately like to employ. So we're trying to correct that by doing more resident training in our FQHCs. And then number 4 is practice style enhancement. That is, there's no sense in getting kids excited about primary care careers, assisting them and nurturing them through those pre-professional and professional training years, having them come successfully to our FQHCs to practice, and then having them experience a very negative practice environment, one in which they don't get to do what they thought they would be able to do when they trained, one that they don't find meaningful, one that they don't find satisfying, and especially now every other article I read is about burnout. We don't want them to experience burnout in our settings. We should be the one place that these primary care clinicians can go to successfully achieve and experience the joy of primary care. So we wanted to hit all four parts of this workforce need that we see existing, and didn't want to skip any of the pieces, because we thought if we left any of the links in the chain weak, that it would probably disrupt the effort. So I've got four pieces going on statewide that relate to workforce enhancement. We're going to go to the next slide, and I'll describe just one of those four prongs, and that's the Primary Care Workforce Initiative. This started in 2015, and basically we were able to start this up largely in alignment with Medicaid expansion statewide. When Medicaid expanded statewide, we took what used to be a large percentage of our patients that were uninsured, and now they were basically covered by Medicaid. That allowed us, great opportunity to have some flexibility in areas of growth and expansion, but it also dramatically decreased our uninsured population, and our legislature was very much aware of that and said, well, then you won't need the state subsidy that's provided to FQHCs to assist you with the high volume of uninsured you experience, which for us was about 35% of all of our patients were uninsured. That dropped down over the next 2 years to about 14%. So the legislature knew we didn't need the subsidy we used to get for uninsured, and before that got zeroed out, because it was on the way there, we went to the governor's office and recommended that we repurposed those dollars to take care of what the whole state was experiencing as a primary care workforce shortage. The governor's office supported us very strongly in our interest in doing that as one way of getting at the primary care workforce need that they perceived but didn't have a plan for. And then the House and the Senate very strongly supported that repurposing of dollars. So at that time, then we were able to bring about $2.75 million a year into our hands to distribute to those FQHCs that were doing teaching in primary care. And for what we were focused on, we went to our FQHCs and we said, who are you having the most trouble recruiting? Where is your greatest challenge? And they told us it's students that they were interested in were medical students, dental students, nurse practitioner students, physician assistant students, and social worker students, because that's who they were having the most trouble recruiting in. Our payment then for student teaching was designed to go to the health center, not to the preceptor, so that the health center would surround the preceptor with a supportive environment for teaching and do what they could in the various components of the health center to interface effectively with all the students that were coming in from this variety of disciplines. To the schools we went to, they were very excited about this because they said they've been talking interprofessional education and had designed interprofessional curricula throughout all these different schools, but they didn't have any good models to show the students that were really in reality in effect. And so we told them and showed them that they could come into our FQHCs and experience interprofessional care that's being delivered in a team care model basis. So we had very strong support from the schools, and we also let them know that we would be expanding our preceptors' numbers for them, which of course was very welcome news as they were all struggling to find more clinical rotations for their learners. To be eligible, though, to be paid as a federally qualified health center, they had to be PCMH recognized. So we wanted our students and wanted to be sure that our students got an advanced primary care experience. And we assumed, and it's worked out well for us, that going through the patient-centered medical home process and becoming recognized at least assured us that they would have the core principles of patient-centered medical home in good order in their centers, so the student could see what could be their future model of care in which they could participate. Right now we have 39 federally qualified health centers that are participating. They are PCMHs and they are participating as teaching institutions, and we have 39 health education institutions that are sending us students. So they develop formal relationships with each other. The students come in various ways at various stages of training, and we basically pay on an hourly basis depending on the type of student that comes and what year they are in training, the FQHC for providing a 1-week experience and 1-month experience. Some of our continuity experiences go as long as 17 months. Where a student comes for a few hours every week. So we've got a variety of different educational experiences that we're hosting and precepting for, and then we pay our FQHCs at the end of the training. In the first year of starting this up, we had 883 students that participated. In our second year, 1,100 students rotated through our FQHCs. Year to date, and this is with 3 quarters done, we've got about 800 students, and we expect to have about 1,200 students at the end of this year, which just ended June 30th. So it's been growing pretty regularly, and we're moving from process measures, which are how many students came through, to outcome measures now. That is, did we achieve the triple aim that we had with this, and that is, do we keep students oriented towards primary care careers who rotate with us? Secondly, do they stay in Ohio, which is one of the legislature's real areas of interest, because these are general revenue fund dollars supporting this from taxpayers. And third, do they go to underserved areas, hopefully where our FQHCs are or other underserved areas. And of course, the legislature would like to be sure they're also accepting Medicaid patients and providing care. So we're now moving into the outcome measure capability because many of our early students have now graduated, and we can track them into their practices. For our medical students that started as first, second, or third-year students, none of them have finished residency training yet, but we track them every year by updating our database with all of our students. We have them sign a consent form for us to stay in contact with them with annual updates, and so we track their progress along their career. So that's what we've tried to do in one area, one of the 4 components of our workforce plan, to see if we can't get more students into our FQHCs, and their responses have been very positive, not only for the quality of the experience that they're having, but also for their eyes being opened to what an FQHC is and the fact that they could also serve in this kind of a role in their future careers. So many of them are considering careers with FQHCs now because of the experience, and we have quite a few of them, especially our nurse practitioners, PAs, dental students, and social workers who have already graduated and been hired into our FQHC statewide. I'm still waiting on the medical student thing, folks, so that's coming, but we're very hopeful that they'll also have pursued a primary care career. They'll stay in Ohio and hopefully come to work for us in our FQHCs around the state. So that's all I wanted to say, and I'll save anything else for any questions and answers at the end. Thank you.
Thank you. Rachel?
All right, thank you so much. There's been a lot of great information already, and I'm excited to touch a little bit more on that and then also speak to some of the barriers that you all have already been discussing. So as they mentioned, I'm Rachel Marino, and I'm the Administrator for Behavioral Health Operations with Valley Health Systems, which is a federally qualified health center located in West Virginia, and then we do have one health center in southeastern Ohio. So we actually serve the tri-state area, which is West Virginia, Kentucky, and Ohio. So we are the largest FQHC with over 30 locations, including WIC and school-based health centers. We offer primary care, including pediatrics, internal medicine, and family practice, OBGYN, dental, optometry, ear, nose, and throat, behavioral health, and then we also operate 3 pharmacies. So we serve roughly 70,000 unique patients each year, and we have over 500 employees. So today I'm going to talk a little bit about the services that we offer in terms of integrated primary care, how our Department of Behavioral Health is structured, and then speak a little bit more specifically to medication-assisted treatment or other types of treatment for opioid use disorder. So for all of our patients in the primary care setting, this also includes OBGYN and pediatrics, we are, operating under an SBIRT model, so we are screening at least once a year every one of our patients with a PHQ-2, and if it's positive, then moving on to the PHQ-9, the CAGE-AID for individuals 18 and older, and then the CRAFT to identify substance use issues. So if anybody screens positive, either with those screeners or just outside of that in their visit, they identify as having an issue or there's a concern, a warm handoff will occur to one of our behavioral health providers at the site, or a referral is made to an internal or external behavioral health provider for mental health or substance use disorder services, including medication-assisted treatment if that's the appropriate treatment option. So one thing that Valley Health has actually invested in, and it's not a reimbursable service, is behavioral health advocates. So our behavioral health patient advocates actually help streamline our referral process for mental health and substance use disorder services. So they manage all of those referrals, so if someone screens positive, and those referrals will go to them, and they help set our patients up with the most appropriate level of care based upon location, provider, and individual needs. They're also addressing social determinants of health and barriers to engaging in services. So if somebody doesn't actually have insurance and they need assistance applying for insurance, or they're underinsured and they have a large copay or deductible, transportation issues, housing issues, and so forth. So in our Department of Behavioral Health, I like to look at it as 3 different service lines. So first, we have 18 therapy providers. That includes doctoral level psychologists, licensed professional counselors, and licensed clinical social workers. We have 4 medication management providers, 3 psychiatrists, and 1 psychiatric mental health nurse practitioner. And then we also have 2 pre-doctoral psychology interns. We are getting ready to conclude our first year of our internship program. And then in the next 3 or 4 months, we're adding additional 2 medication management providers and an additional 3 therapists. So one thing that's actually been really helpful for us, and Ted was speaking about this a bit in terms of workforce development, is for the past 5 years, we've been partnering with the Marshall University School of Department of Psychology, and we offer practicum training rotations for individuals in the PsyD program. So we've actually been very successful in that training, and we've been able to recruit individuals to come back to either attend internship with us, postdoctoral fellowships, or come on as licensed psychologists. So that's been great, and we're continuing to establish relationships with the social work and counseling department as well. So in those 3 different areas, we have integrated primary care, modified outpatient and specialty programs, including medication-assisted treatment and dialectical behavior therapy. So starting us off is integrated primary care, and one of the things that I love about integrated primary care is how our behavioral health providers look at that service line. So if Valley Health serves 70,000 unique individuals on a yearly basis, our behavioral health providers say, I have 70,000 unique patients, because they truly work alongside with our primary care providers to provide holistic care to each one of our patients. So the behavioral health providers are embedded in the primary care practice. They're available for warm handoffs and short-term follow-up services, typically 4 to 6 sessions. They assist with the management of chronic conditions such as COPD, hypertension, diabetes, obesity, anxiety, and depression. So they're not just working on what people would typically define as a mental health issue. So they're being called in to also discuss, behavior changes, or if someone has COPD and they have a fear of not being able to breathe and so forth. The interventions are very brief and solution-focused. So within the integrated primary care realm, we're also offering an integrated consultation service, and I know that some other health centers have been successful at implementing this as well. And to me, this is one of the most valuable services that we offer. I'm sure as many other places experience, we have a shortage of psychiatry providers in this area. And what we were finding were people were waiting, 3, 4, 5 months to get in to see a psychiatrist or a psych nurse practitioner. So our section chief and one of our behavioral health providers decided that it was time to start an integrated consultation service. So what happens there is our primary care providers do a warm handoff to our behavioral health provider. That behavioral health provider performs a diagnostic assessment and gets additional information that's necessary for a psychiatrist to make medication recommendations. That case is presented to a psychiatrist. They review the entire medical record and then make a recommendation to the PCP for medications. So the psychiatrist never actually sees the patient, so we're not adding, individuals to that psychiatrist caseload, but the PCP makes the initial prescribing, and they continue to check in with that patient on a weekly basis and monitor how they're handling their medications, and the BHP and psychiatrist meet on a weekly basis. So turnaround time for that is 2 days. So our patients are getting med recommendations in 2 days, and our PCPs can initiate those med recommendations, at that same time or at the next visit. So that's opposed to waiting, for services for 3 to 4 months. So in addition to integrated primary care, if somebody needs longer-term follow-up services, we have modified outpatient. And one of the primary reasons we have modified outpatient services is because we also have a shortage of these services in our area. So after, we saw somebody for 4 to 6 sessions in integrated primary care, there was nowhere to refer our patients to for longer-term services. So these individuals that we see in this section of the department, they can self-refer, they can be community members just calling in, they can be referred from a Valley Health provider or community providers, and we're addressing a wide variety of mental health and substance use issues through therapy and medication management, if appropriate. Our initial assessments are typically 60 minutes in length, and most follow-up appointments are 30 minutes in length, which is why we call it a modified outpatient service. This has been a little bit different, and it's a big transition for a lot of the providers that we recruit to the department. Most of them are used to doing 60-minute follow-up appointments. So one thing that that's happened is we've gotten really great feedback from our patients as well as our providers about the 30-minute model. The interventions are brief and solution-focused, and the providers do have the ability to have longer appointments if they need it. But this also increases the access that we can provide to our health center patients. And then individuals may engage in these services for varying levels of time. So, another area of need that we identified being in this area is specialty programs and needing a higher level of care. And we've established relationships with, places, the local comprehensive behavioral health centers and other treatment programs to offer that higher level of care to our patients. But there's also some services that are not being offered in the community, or those relationships, those individuals were already at capacity. So one of the specialty programs that we introduced in May 2017 was a dialectical behavior therapy program. So we offer this program in its general form and then for substance use disorders. So it's for the most difficult to treat conditions. There's chronic and pervasive emotion dysregulation, suicidal ideations. It entails 2 hours of weekly skills group, an hour of weekly individual therapy, and after-hours phone coaching from our licensed psychologists or clinical social workers. So I believe, Ted talked about a little bit earlier is burnout. Our psychiatrists and our other therapy providers were seeing individuals who truly needed a higher level of care, and we were not able to find that for them in the community. So we were fortunate enough to be able to recruit a psychologist who was very passionate about DBT and wanted to start this program, and it has been incredibly helpful to our providers and to our patients. The next specialty program, which we'll speak a little bit more in depth about, is medication-assisted treatment. So at Valley Health, we use both buprenorphine and naltrexone for the management of opioid use disorder, and we also are doing some alcohol dependence treatment. Our programs are comprehensive, meaning we have medication management, therapy, and case management all provided on site. So in terms of medication-assisted treatment, Valley Health started offering this service in 2009. One of our primary care providers had a very strong interest in it and wanted to start offering this to our communities. So since then, right now we actually have 334 active participants in our program, spread across 2 health centers that offer both buprenorphine and naltrexone. We have 1 health center that offers Vivitrol only and works predominantly with the drug court system here in Cabell County. But in 2017, we served 473 unique individuals, and that number continues to grow. So we do see pregnant women, and we do work the justice system through the drug courts, and postpartum women as well. So we have 6 physicians, 4 family practice and 2 psychiatrists, 5 family nurse practitioners, and 12 therapists all working in the program. So that could either be, some of them are working full-time, others are part-time. But one thing that we've also noticed is it's important to provide diversity in the caseload for our providers. Many of them have different interests, and we want to make sure that we are nurturing them in their careers and allowing them to explore different areas. So someone may only work in medication-assisted treatment for 8 hours a week, and then the rest of that week maybe they're doing DBT. So we've been pretty successful at that, and notice that it's reduced our burnout rate amongst our providers. So in the medication-assisted treatment program, we have many different referral resources. We have our internal services, so from Valley Health Primary Care, Behavioral Health, OBGYN. We also work closely with the Neonatal Therapeutic Unit and Lily's Place, which are programs here in Cabell County that take care of babies that are born exposed to substances in utero. We work with other treatment programs, the Harm Reduction Program here in Cabell County, the Quick Response Team, which was developed in Huntington, and actually Colerain, Ohio. It's modeled after the program in Colerain, Ohio, but a team of clinicians and firefighters and police officers go out and meet individuals within 72 hours after they've overdosed, and they make a connection with them, and they try to get them into treatment as soon as possible. So we take a lot of referrals from them. We're probably receiving around 10 a week. We also work with Project Engage, where the hospitals are trying to identify individuals who have substance use issues on their units and referring them to appropriate services, also community primary care and OBGYN providers, and by self-referral. So we also, one thing that I think is unique is we take care of the whole family, so in terms of other substance use treatment providers in our community. So one of our MAT medical directors at our Hylon Health facility provides MAT services to a general population, including pregnant and postpartum women, and then he also goes to the hospital, to the Neonatal Therapeutic Unit, and to Lily's Place to take care of babies that were exposed in utero. So he's seeing kind of the whole lifespan, and then those children often end up back in our pediatric care, and then may follow up with child and adolescent psychology and psychiatry services if necessary. So some of, our successes and some of our challenges, and these have already been touched on just a little bit, but success is one of the biggest things. If there's one key takeaway from today, is collaborations. This really started for us, about a year and a half ago, really realizing that, we can't, nor can anybody in our community work to solve this issue alone. And there's quite a few healthcare providers in our community, and historically, there is some competition, but when it comes to this type of service, or any services where people just need help, that's something you have to put aside. So collaborations are crucial. We work with our local hospitals as well as other healthcare organizations. We do training programs in terms of our successes with the PsyD students, as we previously mentioned. We also have recently opened up moonlighting or leasing opportunities. So, if we can't hire somebody full-time to come work with us, if we can't hire a primary care provider or they don't want to do MAT full-time, we've opened up the opportunity to lease them for 4, 6, 8 hours a week from their current employer to provide those services, and then we make sure everything's taken care of for their patients when they're not at the health center practicing. We've also added peer recovery coaching on site. We added a peer coach to work with our pregnant and postpartum women. That was through a collaboration with Recovery Point, who's actually an abstinence-based program. So one thing that we recognize is while we, consider ourselves experts in MAT and we've been offering this for a significant period of time, it is not, the only option for recovery, and it is not the best fit for every individual. So we want to see, what's going to work best for each one of our participants, and then also offer as much supportive services as we can, including peer recovery coaches. This was touched on a little bit earlier, but other successes would be the Medicaid expansion. It's hard to imagine, what that would look like if, I imagine that a lot of our participants would lose that coverage. We also serve Kentucky, so I think there was a comment about other legislative changes in terms of workforce requirements, and so that was something that we were preparing to address if that was going to go through. We've also been successful at receiving different grants to help offset some of the financial costs of running these programs. We did receive the AIMS grant through HRSA, we received the SACE grants, and then we will be applying for additional funding as we move forward. Some of our challenges, stigma. Even though we've offered substance use treatment services and behavioral health since 2009, we still, work to address stigma in each of our health centers. We have over 30 locations, so it's ongoing, and as well as in our community too. The recruitment of qualified professionals to provide therapy services. We have a workforce shortage, but we continue to make sure that we are doing everything we can to get those individuals into providing this service. We also have state regulations that came out a couple of years ago that were pretty burdensome on MAT practices. So we have to register now similar to an opioid treatment program within our state. And that was a bit of a barrier to other places opening up services, but as we had a pretty good infrastructure, we went ahead and offered our services to other community health centers as well as healthcare organizations to help them stay operational and register to be an MAT program. And then one of the last things in terms of challenges, I mean, we have space at existing health centers, so some of that infrastructure is challenging. We share offices with OBGYN, pediatrics, and we're balancing, you know, using group rooms and increasing access there and how that can impact the primary care practice. And then also financially as well. We receive a fee-for-service rate for our group therapy rather than our PPS rate, which is different, and that has posed some barriers for us. And then also for our integrated consultation service for the psychiatric consultations, we don't receive reimbursement there either. But we use grants to offset those costs, and also, you know, some of our department and programs do better than others, and we look at it as a whole. So while we have some of these challenges, what I would say is they're challenges. It's not impossible to overcome them, and that's one thing I'm so appreciative about with working for Valley Health and with the providers in our programs is that there's a way. If there's a will, there's a way, and it's about being creative, forming those relationships, and truly continuing to try to fulfill your mission in order to help individuals with these issues and those who are underserved. So I really appreciate everybody's time today. I hope that gives you a good overview of the work that we're doing here, and we're always more than willing to answer any questions that you have in terms of starting these programs at your health centers or expanding upon them. Thank you.
Thank you, Rachel. This is Bethany Hamilton again from the State Affairs team. We would encourage everyone, again, to go ahead and submit any questions that you might have for today's panelists. We heard from Jen Taylor, Dr. Kima Taylor, Dr. Ted Wilmslow, and Rachel Marino. We've covered a bit of federal updates. Dr. Taylor shared what she learned by speaking to the field, including PCAs and health centers. And then we heard from Ted Wilmslow at the Ohio Association of Community Health Centers about what they're working on for the state of Ohio and some of what they focus on in terms of workforce development, the initiatives that they're focusing on for the primary care field to really build that up. And we also heard lastly from Rachel Marino at Valley Health Systems in West Virginia on what their robust program has developed into, but what additional barriers they continue to see. So I encourage everyone to submit those questions via the chat box in WebEx. What I will do is just bring everyone's attention to a couple of questions that we put in there to try to find out who you are and where you're from. That way we can sort of tailor some additional feedback here at the end of today's webinar, which will end, by the way, it's an extended webinar until 3:15 p.m. Eastern time today. That way we can provide enough ample time for your questions to be answered. So one of the questions we put in the chat box is, what sort of organization are you representing today? Are you from a health center, a primary care association, a state or federal agency, or some other type of organization such as media, or another trade association from the primary care or other healthcare field? Let us know where you're from. I know we have several PCA policy folks currently logged in. Also, in addition to telling us where you're from so we know a little bit more about the audience and what questions or where your interest may lie, tell us a little bit more about if your health center, if you are a health center, or if any health centers in your state have actually implemented an integrated consultation service. You heard Rachel Marino talk a little bit about what they've done at Valley Health Systems in this regard. It could be unique, or it very well could be more common than we think here at the National Association. So tell us more about that if you have an integrated consultation service at your health center. Also in the chat box, I just want to bring your attention to a couple of more questions, a question that we posed to really get you guys thinking and really posing some more questions and feedback to us. tell us more about what sorts of non-healthcare stakeholders you're working with. So are you working with primarily the housing providers or support folks in the community, criminal justice system, civil legal services, so your legal aid folks in your state, workforce development, food resources, or transportation? Let us know who else you're working with in your state or at your health center to really develop that behavioral health or SUD, OUD treatment service or program. All right, so I'll pause right there for a moment to see if we have any additional remarks from Dr. Taylor. Dr. Taylor, would you like to provide some closing remarks? I have no questions currently coming in, but I do encourage folks to just type them into the chat box.
Sure. I guess I would, again, really like to thank the people who participated and to say that I am available for other questions. There's obviously much more underneath than we were able to present now, but it's been a really exciting opportunity. If you have follow-up questions, definitely feel free to reach out. And a special thank you to Ted and Rachel as well.
Thank you so much. Dr. Taylor, Dr. Wilmslow, Rachel Marino, and Jen Taylor, I just want to thank you all for joining today's webinar. A couple of closing remarks from NAC. The State Affairs team will be cleaning up this recording to make sure that it is actually audible in all ways for everyone. We'll have a slide deck available as well, separate from the recording. Just give us a couple of days to get that done, and we'll make sure it's emailed out with a link that you can use to spread the word about the important information that was shared during today's webinars. Dr. Taylor said there's much more to come, particularly from NAC in this area as we work across our teams and divisions to get you the information that you need. And by the way, the information you need is based on what you inform us of. So I would encourage folks to continue to communicate with us between everyone from our clinical division to our policy shop and our TTA and several other divisions involved in this very important work. So again, this is Bethany Hamilton. We're going to close it out from here and wish you all a happy and productive week. Thank you everyone for joining us on today's webinar.